Good morning. My name is Jerry DiColo, and I'm the Metro Editor of the Times-Picayune New Orleans Advocate. Thank you for joining us today for a roundtable discussion on the COVID-19 pandemic. Our panel of medical experts will discuss what it's like to be on the front lines of Louisiana's fourth surge, and will answer your questions about COVID treatments, booster shots, hospitalizations, social distancing, masking, cases in children, and more. First, we'd like to thank our sponsor, AARP, and here's a short video message from them.
Hello, I'm Bobby Savoy, AARP Louisiana State President. Like you, I just want life to get back to normal. Many of us are eagerly awaiting football season, tailgating, and fall festivals. And with thousands of people getting the vaccine every day, we're making progress. But we still have a lot of work to do. AARP is proud to sponsor today's roundtable to help get the information we need, whether it's facts about the vaccine or how we can safely get back to the life we want to live. We are also encouraging everyone who is eligible to get vaccinated, to protect ourselves, our loved ones, and end this pandemic. Sleeves up, Louisiana. We can do this. The choice is ours.
Now I'd like to introduce health reporter Emily Woodruff, who will lead today's discussion. Emily?
Thanks, Jerry. It's really been my privilege to report on the coronavirus since January 2020. It's hard to believe it's been over a year and a half now that we first started hearing about it, and we're in our fourth surge in Louisiana. None of my reporting would be possible without the experts, and today we have three of them, all of whom have been really helpful to me, not just with my reporting, but also understanding the science of the virus. And what they've told me has helped me make decisions in my own life. So today I want to give everyone else the opportunity to ask them questions. Here today we have Dr. Kara Ward, who specializes in both emergency and critical care medicine at LSU Health Sciences Center. We have Dr. Julio Figueroa, Professor and Chief of Infectious Diseases at LSU Health New Orleans School of Medicine, and Dr. Mark Klein, Children's Hospital Physician-in-Chief and Clinical Professor of Pediatrics at LSU Health New Orleans School of Medicine. Thank you all so much for being here today. I know you're very busy. You're all in hospitals right now. So I want to leave as much time as possible for questions from our audience. We got almost 100 questions, but I also want to give people just a sense of what your day to day is like, what you do, what your role is. So maybe Dr. Ward, you could start and just tell us a little bit about what the pandemic has been like for you and what your role is exactly.
Sure. So thank you, Emily. So I am an emergency medicine physician as well as a critical care physician. I'm board certified in both of those. For the pandemic, I've been mainly utilized in the critical care world, as that is where my help has been most needed. My day-to-day involves sometimes 5 a.m. starting my day, reviewing patients, seeing who's been admitted. Triaging is part of my job, is who is sick enough to actually need me, who is really sick, but maybe we can get by of having them on the floor, which is something that we've not had to do until recently. So my day-to-day is coordinating care from head to toe for patients, whether it's just related to COVID or if it's related to their heart, it's related to their lungs. And it's much more intense this time around on this fourth surge than it has been in previous surges, I would say.
Yeah, and I know you've been working throughout all four surges, so I'm really glad we can have you here to share that perspective with us. Dr. Figueroa, tell us a little bit about what you do, your expertise, and what your days have been like during the pandemic.
Sure. So I would say that as Dr. Ward described, it's kind of changed over time. So I do two basic parts of my job are seeing patients with COVID-19 and sort of helping the teams take care of them in terms of any antibiotics that are necessary or any antivirals or those sorts of things. And that has evolved over time. The other part that I've been involved with is helping the hospitals keep as many people safe as possible. So infection prevention and those sorts of aspects that have become very important, as well as trying to understand with my colleagues in critical care and in pharmacy, the new interventions that have, as they've been rolling out. So trying to look at data to be able to say, well, this drug is really very effective and should be used in this population versus this drug that may be not so effective, or the population is a different population that we want to use. So right now we have a pretty good idea of what drugs work, what interventions work, and what interventions don't work. And so that's a lot better than what we were in March and April of 2020.
Yeah, and we've talked, I think, since February 2020 about this virus, and you've walked me through the vaccine trials and all the treatments. So I'm really glad to have you here as well. Thank you. And Dr. Klein, tell us a little bit about what you do. You're at children's hospitals. What has your day been like lately?
Well, thank you, Emily. I really appreciate the opportunity to be here this morning. I'm a pediatrician and an infectious disease specialist by training. And my role at Children's Hospital New Orleans is to be the physician in chief. And so I oversee the other specialists who work at the hospital. Because of my special expertise in infectious diseases, I've been heavily involved in the COVID response here at the hospital. I spend a lot of time every day dealing with the availability of beds in the intensive care unit and on the acute care floors, working with the doctors, getting patients into the hospital, hopefully getting them well enough to get out of the hospital, and a myriad of other subjects that are really attached to that. COVID, of course, has put a big strain on our hospital, as it has on all of the adult facilities across the state. And we've caught a little bit of a break just recently because we were dealing with a second respiratory virus, RSV, that seems to have abated at this point. But COVID is still a huge concern for us. I would say probably the number one thing that I'm dealing with day in and day out at this point.
All right. Well, we received a lot of questions. I think most of our questions were, not most of them, but the most questions on one topic were were about children. So really glad to have you here as well. Okay, so I'm gonna jump right into our questions so we can get through as many as possible. And the first one I want to address, it's a little heavy, but We've heard a lot about hospital capacity lately, right? Like the hospitals are full, people are being sent home or maybe, their surgeries are being delayed. And a lot of people have asked me, and this question came in a lot, why can't hospitals limit the number of beds allocated to non-vaccinated patients so that, and this is this person saying that, so that people who did the right thing do not die? And Dr. Ward, I remember we talked a little bit about this idea of, well, should we limit beds for non-vaccinated patients? Because that's a lot of what you're seeing, right?
It is a majority of what I'm seeing in the ICU are unvaccinated.
So when you hear that question, which came in from a lot of different people, what do you say to those people about this idea of not giving care to unvaccinated people?
It's, again, I understand where it's coming from, and people are frustrated and scared. But at the same time, I've had many unvaccinated people that have just gotten bad information. That if they had gotten the right information or had someone that they trusted direct them, they would have been vaccinated. And again, these are young people. The majority of the unvaccinated that we're seeing are younger, they're healthy, and at this point, it's not my job to judge you, and it's not my job to be God, basically, and say who gets treated or not gets treated. It's my job to treat everyone the same way, whether you've made a choice and for whatever reason or didn't make it. So it's not as simple as that. It's not as simple as just saying you didn't make a great choice, because the reasons behind those choices are just so vast and so individualized.
What's some of the bad information that you hear?
I hear all kinds of things from the vaccine came out too early, they haven't tested it, it could affect my fertility. I see that in a lot of young women, especially who are trying to get pregnant or hoping to be pregnant, or even are pregnant, that they are worried about their fertility. There are people that said, oh, I read on the internet that, it's not safe and we don't know the complications, or the misrepresentation now that people that are vaccinated are getting COVID, which is true, but it's not at the same level that people who are vaccinated. So there's a lot of misinformation that gets spread very wildly, and fear is a very powerful motivator.
Mm-hmm. Dr. Figueroa, is that something that, people have said to you about, oh, let's limit the beds, and we've talked about the thousands of surgeries that have been delayed, and the people who suffer, and have suffered and will suffer for years because they're not getting the same care that they might. What do you say to those people?
Well, I think that at the very beginning of the pandemic, when we were basically dealing with hundreds of patients at a time, the health systems decided, and I think rightly so, that we needed to kind of focus our attention towards those individuals that were sick, and so to try to push off things that were not as necessary or could be delayed a little bit in terms of that. What we found over time is that there are impacts to that. And so over time, what the health systems have been trying to do is to try to absorb that capacity as much as possible, which is kind of where we are right now. And so that some health systems are able to do it more than others. The other thing that sort of impacted us is the fatigue factor, and also the loss of healthcare workers because they themselves are getting sick because of the Delta variant, and so loss of healthcare workers there. And so consequently, what we're trying to do is a balancing act. What I would say, though, is that we took oaths to take care of the sick. And so in whatever situation you're in, that's what we're supposed to do. So we try our best to do that as much as possible.
Okay. And Dr. Klein, I don't think anyone really is talking about children when they say this. I don't think anyone blames children, even when they are, 15 or 17 and they're eligible to get vaccinated. But is that something you've seen as far as having to sort of redistribute your resources at the Children's Hospital?
Certainly, we have been in a position of having to redistribute resources, and I guess just start by echoing what Dr. Ward and Dr. Figueroa said. It's not our role to pass judgment on why anyone is in the position that they're in. We don't look at someone who's come into the emergency department after an automobile accident and ask whether they were exceeding the speed limit before we decide whether to treat them. And so people make all kinds of choices, and some of those are not necessarily good choices, and there are consequences of those, but it's not our role to pass judgment. But as far as the Children's Hospital goes, we have delayed some non-time sensitive surgical procedures. And what really is limiting for us is the availability of staff. In the early days of the epidemic, we all heard about the availability of protective equipment and of ventilators and that sort of thing. Those are not rate limiting. Medications are not rate limiting. And even bed availability is not rate limiting for us. It is simply the availability of staff. And so we've pulled nurses who are assigned to administrative roles back into the inpatient areas. We've moved nurses who are working in our outpatient clinics back into the inpatient area to help us cope with the numbers. We've done a lot of things, and we're doing our best to recruit and onboard nurses and respiratory therapists and social workers and so on. But this is a big challenge across the state. It's not unique to New Orleans or to Louisiana even. And the fact fact of the matter is, we haven't seen anything like this before, and COVID is putting a real strain on health systems, and we're doing the best we can. I would just say one other aspect of this is where children are concerned in particular, they don't have a lot of options. So if the Children's Hospital says, sorry, we're full, we don't have any more room to take care of a seriously ill child, that child doesn't have, 2 or 3 or 5 other hospitals that they can go to in the region. They may have to try to go to Houston or to Birmingham or to Atlanta for treatment, and that's just not practical for a child who is critically ill. So we've got to work hard to make sure that we can accommodate every child who needs us.
Yeah, I think when we say hospitals are full, people don't necessarily realize that means that there just aren't the people there, that there just aren't enough people to check on the medications and check people in and talk to everyone and make sure everyone's getting their care. So that's a good point. I want to go back to something, Dr. Ward, you said. We got a lot of questions about, if you can spread it when you're vaccinated, what's the point? I'll just read it. It says, if you can still spread COVID, even though you're vaccinated, and you can test negative, but then become positive in the next 72 hours, what's the point of these test requirements? Other people said, I have natural immunity, and I think that should be more emphasized. What do you see in the ICU as far as reinfections and unvaccinated? And just share that with us.
So, it's a great question, and it's been very prevalent in the community. There are some unvaccinated or vaccinated people that we're seeing, but they tend to be the patients that are sicker at their normal baseline, walking around every day. These aren't patients that are healthy. These are patients that are on long-term dialysis. These are patients that are getting chemotherapy. These are patients who are on drugs for, things like arthritis or Crohn's disease or something else. So these aren't the healthy patients of what we're seeing as the vaccinated. There are still hospitalizations of vaccinated patients, but they're not requiring to see me. I'm not seeing those patients, which is a good thing. So I would still strongly encourage everyone to get vaccinated. I will say, speaking just from a personal experience, I actually had COVID twice last year and was first in line to get my vaccine as soon as possible. Because yes, there is maybe some natural immunity with antibody formation with getting COVID. We just don't know how much it is, and everybody varies differently. Whereas the vaccine actually forces your immune system to create natural antibodies. The vaccine is not antibodies. It is making your body create these natural antibodies at a much higher dose that we know is more protective. So I encourage absolutely everybody, whether you've had COVID or not, to get the vaccine.
Do you see patients who, I'm not sure how much they can communicate with you, but do they say, oh, I had it and, whenever in 2020 and they didn't realize that they could get it so bad again? Is that something you've run into?
There's been some of that, not as much. I think most of the people that had COVID in 2020 were scared enough at that point to get the vaccine when it was available. There are some people who said, oh, I had it recently. I thought I had to wait for 6 months, which I'm not sure where that data is coming from or where that idea that you have to wait to get the vaccine. There is some data, if you get monoclonal antibody treatment, you wait 90 days, but that is really the only data we have. So I think there's some false information and false sense of security that people have that, oh, I had COVID, so now I have antibodies. And that's not the case.
And Dr. Figueroa, I know we've talked a lot about, what the vaccines are really meant to do. So what would you say to someone who says, I'm healthy, I think I had COVID, I don't really need the vaccine, right? Or, what's the point if even the vaccinated can test positive and spread it?
So let me address the vaccinated can test positive and spread it part first. So that is true that some vaccinated individuals have been shown to be able to have the virus in sufficient levels in order to transmit to other people. But more data evolving as we understand this and showing that window is a lot shorter in those individuals rather than the unvaccinated, which is a lot longer. The second is that the viral load seems to be less in terms of the ability of actually to detect the virus in the secretions, which is kind of what causes the transmission. So, I mean, I think that even though there are people who have breakthrough infections with vaccination, it's still a public health imperative to get people vaccinated in order to reduce that time of transmission. So that's very important. The second, to reiterate what Dr. Ward mentioned, is that the variability of natural infection in terms of inducing an immune response is very wide. So that you have individuals who have very good immunity and other individuals who don't have good immunity, and that wanes over time at different rates as well. The third is the fact that the variants are very important in this equation, because you may have had the original strain, but that particular immunity that you had is no longer effective against the Delta variant or other variants that are coming. While the vaccines seem to give you a broader protection against a various number of variants that have been identified so far. So those are all reasons to get vaccinated.
And Dr. Klein, I know we've talked a little bit before about why it's important to kind of surround children right now with vaccinated people. Tell us about that.
Well, Emily, you've got a whole cohort of children under the age of 12 who haven't been eligible for vaccination. We hope that maybe by the end of the calendar year, we will have at least emergency use authorization for administration of vaccine to children, maybe in the 5 to 11 year age group. But today, the only group of individuals in the country who are 100% unvaccinated are these kids under the age of 12. And so they don't have many options in terms of protection. They depend on the adults who are around them to provide that protection. And so that means not putting them in dangerous situations like indoors with crowds of individuals who may be unvaccinated and who could be infected, or even outdoors with large groups of individuals unmasked. And so the best we have to offer for children really is to surround them with adults who are doing the right things, masking up, and hopefully adults who have been vaccinated and therefore who are unlikely to transmit to them. Most of the children that we have seen admitted during this current surge, admitted to the hospital with COVID-19, have been infected by unvaccinated adults in their immediate environment. Sometimes that's their parents, sometimes it's an aunt or an uncle, it could be someone else. But I've talked about cocooning children, if you will, surrounding them with masked individuals, if necessary, people wearing masks to prevent transmission, but particularly surrounding them with adults who've done the right thing and been vaccinated. And then you've got the adolescents who are 12 years of age and up, and those older children and adolescents, they are eligible for vaccination. They've been eligible since May under the FDA's emergency use authorization for the Pfizer vaccine. And in Louisiana, only about 13 or 14% of those individuals have been vaccinated so far. So we've got a long way to go there. We have had about 35 children, adolescents in that age group who've been admitted to Children's Hospital New Orleans over the past 6 weeks, and only one was fully vaccinated. The others were either unvaccinated or only partially vaccinated. So we've got to do a better job of vaccinating that particular group.
Yeah. And we did, like I said, we received a lot of questions about kids, so I'm going to try to get through some of them. One person wants to know, is the only way for a child to contract COVID, is it from adults, or can one child infect another child?
It's an excellent question. In the early stages of the epidemic, some people said, well, children hardly ever become infected. If they do, they don't transmit, they don't get sick. That was all myth then. It's certainly myth now. Children can get this infection. Children can transmit the infection. And so that's the real concern in schools. We've got a prevalence of COVID among children in New Orleans right now that probably is in the range of 10 to 15%. That's what we're seeing across our outpatient sites. And, if you throw those kids into a school type setting where you aggregate or congregate 25 or 30 children in a single classroom, hopefully everyone's masked up and that offers some protection. But you're likely to see some spread in the schools from child to child or from child to a teacher, perhaps, who is unvaccinated or a staff member. And so that's been a real concern to us as schools open up, is that will cause sort of a surge on top of a surge. I think we're fortunate to be here in Louisiana because both the mayor has instituted indoor mask mandate, as everyone knows, and the governor, a little more than 3 weeks ago, instituted a statewide mandate that pertained to children in the schools 5 years of age and up, as well as to all teachers and staff members. So everybody should be wearing masks, and that should help to eliminate some of that. But the answer to your question is yes, children can transmit to one another, and children can transmit to adults.
And you mentioned that 5 years and up, they should be wearing masks in any situation. But we did have a lot of people write in about their young children. One person said, how can I protect my kid from COVID? I have a 2-year-old daughter and I worry about sending her to school, which is, I think, daycare. What do you say to those people?
Yeah. So the governor's mandate pertains to children 5 years of age and up. The American Academy of Pediatrics actually recommends masking for children as young as 2 years of age. And a lot of adults respond to that by saying, there's no way you're going to get a 2-year-old to wear a mask. And I think it's probably case by case, variable. There's some variability. Some children can do it and some don't do it as well. I've had parents say to me, my 2-year-old, my 3-year-old wears a mask just fine. It's just an item of clothing. It's like, having them put on their socks or shoes. And I was actually at the screening desk at the front of the hospital the other day, and a mother came through and she put on her mask, and the little toddler that she had with her, who was probably 3 years old, immediately began crying because she wanted her mask too. It was like like bling or an item, a style statement or something. And the mom said to me, if I forget to put her mask on, she cries. She wants to be like me because I have a mask on. So some people have a lot of success with it, but under 2, probably not practical, but starting at age 2, there are some kids who can wear masks. And if they're in settings where there are a lot of people and of unknown vaccination status, we would recommend that they try to wear a mask.
Okay. Dr. Ward, I see you nodding along. I know you have a young child. What do you say to people and what do you do to keep safe? And what is your kind of risk tolerance, I guess?
I very much empathize with this parent. I am a mom of a 2-year-old myself. So I very much understand the fear and the risk associated. I would agree with Dr. Klein. My 2-year-old at times is great with a mask, at other times is not so much. And, she's just being a 2-year-old. So kind of allow for that. Things that I sympathize with parents who need to work and need to go to daycare. So if you can try to have your child wear a mask, or seeing what the number of kids in a classroom are, those are kind of risks that you can kind of mitigate a little. For myself, I will tell you I'm very cautious with my 2-year-old, partly because I have the luxury and the benefit of doing that. from what I do for a living, and being able to keep her safe from me even. The more fear is that not that someone else is going to give it to her, or that I'm going to give it to her. So vaccinating was the biggest thing I could do to help protect my child. And I make sure that all the adults that are around her, which is a very small circle, are all vaccinated as well. And that's a way that that's a step that I can take to protect my daughter. And that's really the only option I have for her at 2.
Yeah, I think that's a great point to just, as Dr. Klein said, cocoon the children. So a lot of people had this question that involves children about, things seem pretty bad in Louisiana, right? We're at an all-time high, and, we have been for a bit. So this person, asks, should we be shutting down as community spread so bad? Dr. Figueroa, I'll ask you, have you considered, I can remember a conversation with you maybe back in June, and you said, Jazz Fest is gonna not be the Jazz Fest. And, then a few months later, your prediction came true. Should we be shutting down more things?
Well, I think that we have to be very careful in all the different aspects of communal gatherings. So an example would be Jazz Fest, the Saints games and things like that. And so the vaccine mandates and those sorts of things are just starting to roll out. And we'll just have to see how that all works. I mean, there's a lot of consternation at this point in time as to, how do you prove your vaccination status and what happens and the compliance and those sorts of things. But I think that the underlying thing that I want to kind of convey is that we want to be as safe as possible when we do these sorts of things. And that would include vaccination, that would include masking, that would include whatever physical distancing can be done, which is going to change the way things are from what they used to be. Now, the other thing to keep in mind is that that's an additional reason to get vaccinated. Because once we have very high vaccination penetration, we will hopefully be able to get back to some semblance of normal. So for those of us in Southeast Louisiana who aren't vaccinated, that's an important reason to keep in mind that when you vaccinate yourself and you help all these other individuals to prevent transmission, that we can get back to normal more quickly than where we are right now.
So the higher the vaccination rate, the less we have to worry about transmission, really, which is ultimately what we want to drive down.
Correct. The idea, I mean, that sort of brings up the corollary about, how much vaccination do you need and all those sorts of things. And what I would say is that there were numbers being thrown out very early in the pandemic, 70%, 75%, people fixating on that number. We really actually don't know what that number needs to be. What we do know is that with the Delta variant, its ability to cause disease with little exposure is pretty high, and so therefore that we're pushing that vaccination rate, that immunity rate as high as possible is going to get us back to where we want to be.
Okay. Dr. Klein, I want to ask you one more question about children. A lot of people were wondering if they can let their children play outside unmasked. They also wondered about sports. What are your thoughts on that?
Well, outside is safer than inside, generally speaking. But and so, all other things being equal, you're better off outside than inside. But in large groups, if there are a lot of unmasked individuals and people some that have been vaccinated, some that haven't, transmission can still occur. And as far as sports are concerned, it's the same thing. To the extent that there is no physical distancing, to the extent that you're coming in contact with unvaccinated or unmasked individuals, you're going to have some risk associated with that. And as Dr. Figueroa alluded, it's really it's not an all or none thing. It's not this conveys some risk and this other thing conveys no risk. It's about risk mitigation. It's about being as safe as we can be while we hopefully go about our lives in, with some semblance of normalcy. And there's some things that are just, where the risk is just too much and we shouldn't be doing it all. And there are some things that are a little bit of a gray area, and we do what we can to mitigate the risk. And that's the case where, children playing together in groups and where sports and those sorts of things are involved. Let's use the tried and true strategies we have to mitigate risk and try to make them as safe as we can.
Right. Okay, I want to move to treatments, and a lot of people had questions about, what can we do to keep positive cases from becoming hospitalizations? Dr. Figueroa, can you tell us a little bit about the options for people right now, how they've evolved?
So initially, there was a lot of interest in repurposing drugs that were used for other purposes. So the hydroxychloroquine and the azithromycin and ivermectin, those sorts of things. There are very little, if no data to support any of those drugs at this point in time in terms of either prevention or mitigation of severity of illness. So the one strategy that seems to be most effective, and even with the Delta variant, is using the monoclonal antibodies from Regeneron. So Regencov is sort of the trade name for that. So for individuals who are at high risk for progression into severe disease, that's actually what's the recommendation at this point in time. And the hospitals are working out systems and have worked out systems in order to be able to get those infusions, because it's an infusion that needs to be done. There's some ability to do what are called subcutaneous injections. So you actually inject it into just underneath the skin, but that's for certain types of patients. Now there's also a prevention component to that the FDA just recently approved for those monoclonal antibodies. So at this point in time, that's really our best modality to mitigate or reduce severity as well as the appearance of COVID-19 in exposed individuals with high risk.
Okay. Dr. Klein, is that the same for children? What are you able to do for these sick kids?
Yeah, it's more or less the same, Emily. The FDA's emergency use authorization for monoclonal antibodies was for children 12 years of age and up. So we do have that option in teenagers, not for younger children. And fortunately, the rate of hospitalization and mechanical ventilation and death and so on, the most adverse outcomes in children is much, much less than it is for adults who are older or who have other comorbid medical problems. And so we don't deal with the same sort of risk magnitude that the adult providers do. But yes, for kids 12 years of age and up, we do have monoclonal antibodies as an option if we think that child is at risk for severe disease.
And Dr. Ward, tell us a little bit about once someone gets to you, they're pretty sick, right? So what are you able to do?
So absolutely. By the time they get to me, the monoclonal antibodies are not an option at that point. There are some drugs that we're still using. One of them is called remdesivir. It's an antiviral. There are still limitations with this drug. There are limitations whether your lab values, so things like liver dysfunction, how far out you are from sickness, how sick you are, you may not qualify for that. It is also a risk benefit for each patient because it is a volume that we have to give patients, and we know that lungs are not happy when they're wet. So if we have to give a large volume of something, the benefit of that drug is not going to outweigh the risks of what we do to the lungs. There's another, couple of drugs that are on the market. They're a little bit harder to come by. We've had some shortages. Tocilizumab is one of them. It's another antiviral. and it also does not come without risks. So it is a drug meant to suppress your immune system. So with that also comes more infections, potentially. So it's not a cure by any means. So these are drugs that I would say are oftentimes Band-Aids. In kind of like layman's terms, our Band-Aids are kind of buying time as we wait for other things to work. What we do know that works is steroids. We've been giving Decadron high doses in these patients. And then it's good care of people's lungs that we've been doing for years and years, good critical care. And that's the only thing that seems to be effective, and time. And unfortunately, we have no way of predicting whether one individual will do well or one individual will not. There's some things that point to it, things like disease processes that they have underlying. Like say if you have diabetes, you're very overweight, you have high blood pressure that's uncontrolled. Those things may point to you not doing as well. However, we've seen people who are otherwise healthy that have not done well and have no medical problems. So it's not completely the answer. There's something underlying that we just don't know.
I think it sounds like the drugs kind of do their own damage at that point. So I think it's been described to me as sort of a race, like you have to get better quickly or you know, the treatments can cause their own problems.
Yes and no. It's individual response. So we give these drugs, but everybody responds slightly different, and there's no way of predicting their response. So yes, there are certainly side effects. There's side effects for everything we do. Whether we give oxygen has its own side effects. So we weigh those risks and benefits in each patient. So by the time you see me in the ICU, we're trying to take care of you with the best data and the best knowledge that we have at the time to give you the best possible chance of survival.
And I want to get really quickly, we're running low on time. I want to get to booster shots really quickly. Dr. Figueroa, someone wrote in and said, how come after saying the COVID vaccines were working, are they now talking about a booster shot? Do the vaccines really work?
So the vaccines really work. That's, I think, very, very clear. What the data from Pfizer and to some extent Moderna and then J&J just reported today about their own data, which has not been published yet, that the antibody titers kind of wane over time. So in other words, you get a very good response, but then it kind of over time kind of starts going down to a point where some people might benefit from getting an additional dose. So that is one thing. So those are normal individuals, normal meaning, most of us, like myself. There's another group of individuals that the FDA actually did, and the CDC Committee on Immunization Practices actually is focusing on, and that's that immunocompromised group. So these are the people with cancer or getting other types of drugs, as Dr. Ward mentioned. Those individuals don't tend to respond as well to vaccines in general. So that it appears that an additional dose, instead of 2 doses, maybe giving 3 doses of the vaccine may be more effective than just doing the 2 dose for those individuals. So it's going to be actually 2 different things that are going to probably come out of this. One is that normal individuals over time might need a booster shot. The second is that for immunocompromised individuals, in order to maximize the effectiveness of the vaccine, that we may need to alter that to include a 3rd dose in the routine series.
Well, thank you all so much. I think we could stay here all day and answer these questions. I'll just ask you, is there any final thought that you'd like to leave people with? If you could tell everyone one thing, Dr. Figueroa, we can start with you. Anything else you think people should know?
I think the major thing is that vaccines work, and so therefore we need to vaccinate as much as possible. and that this is a real deal. So Dr. Ward and Dr. Klein have been very eloquent in terms of saying what the impacts are in children and in adults. And this is a real disease that is killing people. And so that we have the tools in order to be able to prevent that. And I would encourage everyone to take those tools and use them.
Dr. Ward, anything else you want people to know?
I would echo what Dr. Figueroa says, encourage everybody to get a vaccine. The best way to not see my face in the ICU is to get the vaccine. And then I would just encourage people to have some empathy and compassion for those that are around us, those that are working in the healthcare field, whether we are nurses, doctors, respiratory therapists, even our cleaning crew. We're tired, we're working longer hours. Please have compassion for us as well and for each other. And the best way you can help us is to help yourself and get vaccinated.
Thank you. Dr. Klein, anything else that people should know?
I'd like to say it's been an honor to be on this panel today with Dr. Figueroa and Dr. Ward. Louisiana and New Orleans are really fortunate to have physicians of their caliber doing this work. And I would just echo what they've said already. We have tools at our disposal. We are not defenseless against this virus. If we all do the right thing, if we mask up, if we distance, and if we take the vaccination, everyone who is eligible should take the vaccination. If we do those things, we can put this behind us. If we fail to do those things, we're going to continue to confront new surges and new variants of this virus. And what we're experiencing right now is going to be our new normal. And I don't think any of us wants that for the coming years.
Well, thank you all. I have the privilege of talking to you somewhat regularly, but I'm so glad I was able to share just your insight and your wisdom today with everyone. I really appreciate it.
Thank you.
Thank you, Emily.